Okay, I'll just say yes to that. So I put this slide up to demonstrate a couple of things. Firstly, there are many, many more plaques that look like this at the left-hand side than there are highly evolved stenotic plaques like this. These are uncommon. They're problematic, but they're uncommon. When atherosclerosis develops, it develops systemically in humans. So there are a lot of plaques like this, and we don't know that we have them because there are no ischemic symptoms. It's not causing a decrease in blood supply or ischemia. You're not going to get angina. You're not going to get transient ischemic episodes in your brain, and you're not going to get intermittent claudication because there's no blockage at these points. But there's lots of plaque, and that plaque can rupture. So this is really a key slide that undermines a lot of contemporary cardiology because it demonstrates that about 14% of acute coronary syndromes, so let's call those acute myocardial infarctions, about 14% of all acute myocardial infarctions happen in arteries that look like this. In other words, very prolonged evolved plaques with very narrow lumens. Most cardiac events, almost 70%, happen in arteries that look like this, where there's no narrowing of the lumen, but the plaque ruptures and causes a clot to form. So myocardial infarction and heart attack is a thrombotic event. It's rupture of the inner lining of the artery, followed by thrombus formation that causes the blockage. 70% of all events are due to insignificant plaques. These are plaques that you can't pick up on an angiogram. Sorry, these ones are plaques that you can't pick up on an angiogram because an angiogram is measuring blood flow through the lumen and there's no blockage in those. 50% of people who die suddenly from acute atherothrombosis from a heart attack have never previously experienced symptoms. So we don't do a very good job of predicting who's going to have a problem. And the reason for that is this physiology that underlies the disease. The other thing I wanted to show you is that if we have an artery series like this, and this could show you the progression of atherosclerosis, but I've put a lifespan down here, showing that in early years you have nice clean arteries, but as life goes on, almost inevitably, in most people, you develop some atherosclerotic disease. Now that may never manifest, but in some people it will, and when it does, it's usually after the age of 50 or 60. So once you express the disease, you might have angina, or the first symptom might be a heart attack or a stroke. As I said, mostly this disease is occult or silent until you have a symptom. Then we get involved in what we call heroic cures. We try to do lots of things to fix it once it's already happened. And if it affects your heart or your brain or your eyes or your kidneys or your limbs, these are microvascular diseases, these are micro and macrovascular diseases. You've got a big problem if you're on the right-hand side of this line. But in Australia, at least, we spend about 10% of our GDP on these sorts of heroic cures. We spend about 0.1 of 1% of our GDP on all of the prevention that could occur in this 60-year period. So we're really reacting to the disease rather than being proactive and preventative. And that's a worldwide phenomenon. Same in the United States, it's the same in the United Kingdom. I'm sure it's the same in India. So this brings me to a little bit about exercise, and I'm going to talk about something that we investigated for a long time now, over about the last 20 years, which is a thing that we call the risk factor gap. We went searching for an explanation for how exercise can benefit people in terms of decreasing their risk of developing atherosclerosis. So the first slide I'm going to show you, for those who are not familiar with physical activity literature, is an amazing study that was performed many, many years ago in 1953. It's published in The Lancet. The first author was Jeremy Morris, a very famous epidemiologist. He did a study where he collected data from London busmen, people who worked on the double-decker buses in London. And on a double-decker bus, there's a driver who sits in a chair for 8 hours, and there's a conductor who gives people tickets who walks up and down, upstairs, downstairs, and he does it for 8 hours straight. So it's a really interesting study because you've got two individuals who are usually from the same sort of suburbs, they eat the same sort of food, they usually have very similar characteristics, except one of them is habitually active, the conductor, and one of them is habitually inactive. And what Morris did is he collected data on all of the London busmen and followed them forward to see how many heart attacks they had. And what he found was that there was a 30% difference between those who were active versus those who were inactive. So if you had an inactive job, you were 30% more likely to have a heart attack than if you had an inactive job. Now, 30% is a big number for prevention. Lipid-lowering drugs, like statin drugs, they're responsible for about a 25% reduction in your risk. So 30% is a considerable amount. And this study really put physical activity epidemiology on the map. It was followed by other studies that looked at what we called longshoremen in the 1950s. These were dockside workers who had very physically active jobs. And it compared the dock workers to office workers and found about the same difference in their risk of having heart attacks. There were other studies on postmen versus telephonists, people who were inactive. And again, the data were very similar. And this has been consistent across the literature ever since, that being physically active decreases your risk of having an atherosclerotic event like a heart attack and maybe also a stroke. So the question is, how does this work? Why does exercise decrease your risk by 30 to 40% of having atherosclerotic events? There was a study published now over a decade ago by Aimin Lee and her colleagues. This is data from the Women's Health Study. So another big epidemiological study. And in this experiment, or in this study, they set out to try and determine which risk factors were responsible for decreasing your risk of a heart attack if you are physically active. So if you're physically active, does your risk of heart attack decrease because that physical activity affects inflammatory factors? Or maybe physical activity decreases your blood pressure and that's contributing, or it's the lipids, or it's body mass index or obesity, or it's glycemic control. And what they did is they tried to attribute statistically the contribution of each of these traditional risk factors to the decrease in risk that people have of having heart attacks. And they found that if you add them all together, you get a value of about 35%. So traditional risk factors explain less than half of the benefit of exercise. I'll put that a different way. If you're physically active, the reason that you have less risk of a heart attack can only partly be explained by the effect of that physical activity on risk factors like these things. So there's a big gap in our explanation, and we called this the risk factor gap. And we went looking for other explanations of why exercise is beneficial. And that brought us to studying the arteries themselves physiologically. Here's a picture of an artery in cross-section. The inner lining in purple here, it's not really purple, but it's just for this cartoon, is a single layer of cells which is flattened. It's in contact with the blood, and it's also in contact with the vessel wall. It's called the endothelial cell layer. Then you've got smooth, the basement membrane, and then smooth muscle, which obviously can contract or dilate, and in so doing can increase your vascular resistance and change your blood pressure. And you've got the tunica adventitia. We got really interested in the role of the endothelial cells because there was a discovery made about 30 years ago now that endothelial cells produce a substance called nitric oxide. So here's an endothelial cell blowing up, and there's some biochemistry going on here. But what's happening is nitric oxide gets released from these endothelial cells, and some of it goes up this way towards the bloodstream, where it decreases the accumulation of oxidative substances, and it decreases the infiltration of things that can cause plaque formation. Some of the nitric oxide goes into the wall, where it decreases oxidation of LDL, decreases lipid accumulation, decreases foam cell formation, does lots of good things that are anti-atherogenic. So nitric oxide and endothelial cells are responsible for vasodilation, which decreases artery shear stress and damage, and also decreases blood pressure. Nitric oxide and endothelial cell function are responsible for decreasing platelet aggregation and adhesion. So if you do have a small rupture or a micro tear, you don't get the same level of thrombus formation because this stuff is preventing platelets from aggregating and adhering. There's also a drop in monocyte adhesion and macrophage transformation, smooth muscle cell proliferation, and a decrease in oxidation. So LDL doesn't get as oxidized and trapped on the inner surface. So endothelial cells, we now know, are really important to decrease your risk of developing atherosclerosis and therefore decreasing your risk of heart attack and stroke. Endothelial dysfunction, abnormal function of this lining, is probably the first stage of developing atherosclerosis. All of these other bad things happen if the endothelial cells stop working properly. So it's very much an early manifestation or an early detectable event in atherosclerosis. That raises the question of, well, if endothelial cells are really important to decreasing atherosclerosis, then how do we improve endothelial cell function? So what is endothelial cell function dependent on? And the answer to that, I'm going to summarize. There's about 4 studies that I'm going to summarize in one slide. The first study was a study where they exposed the femoral arteries in dogs on both legs. I'm just showing one here. And they measured the diameter of the femoral artery using ultrasound, and then they modified the flow through the artery using adjustable snares or clamps. So by clamping the proximal artery, they could decrease the flow. By releasing the proximal clamp, they could increase the flow. And they did this in both legs, but in one leg, they put an angioplasty balloon in, and they pumped it up and they rubbed it up and down. And the reason they did that is they wanted to remove the endothelial cells from one side. So in one leg, you've got an artery without endothelial cells, and in the other leg, you've got a normal control artery that does have endothelial cells. When they increased the blood flow through the lumen of the tube, the artery that had endothelial cells dilated. Here it is increasing in diameter. But in the same animal and at the same time on the other leg, when they increased the blood flow through the tube, they got no increase in diameter. So this showed that the endothelial cells were responsible for responding to an increase in blood flow by dilating the artery. And if you don't have endothelial cells, or even if you do have endothelial cells but they don't work properly, when you get that increase in blood flow and what we call shear stress across the wall, these cells do not respond adequately to dilate. And that's a good marker or sign of how healthy or fit the endothelial cells are. And studies like this were done in dogs. There were dogs put on treadmills and they're taught to run on a treadmill. And they did this and measured coronary artery diameter at different treadmill intensities or speeds here. And at low speed, the diameter of the coronary artery dilates when you exercise. Increase the speed, it goes up a bit more. The diameter of the arteries increases more blood flow to the muscle, in this case, cardiac muscle. When you do this test again, after putting an angioplasty balloon into that coronary artery and remove it and let the dog recover, so now you have a dog running on a treadmill who has coronary arteries but with no endothelial cells, you get a vasoconstriction instead of vasodilation. So this is also proof that endothelial cells are really important to the control of artery function in animals. When you remove endothelial cells, this is in rabbits, chronically, and you make sure that the endothelial cells don't regrow, and then you increase or decrease the flow through a carotid artery, you get a chronic reduction in the size of the artery, but without endothelial cells, it doesn't remodel properly. So this sort of study showed that endothelial cells are not just responsible for acute changes in response to increases in flow, but over time, the whole artery changes in size. See how much smaller this gets when you've got endothelial cells. If you decrease the flow, the artery diminishes in size. If you have an artery that doesn't have endothelial cells, you get no remodeling, so it doesn't work. The physiology goes wrong. We've shown this also in humans. This is studies that we did about 5 or 6 years ago, where we used a radial artery as a model, and we put an angioplasty balloon inside one radial artery. We used the other arm as a control, and we repeated these studies and showed in humans this is also true, that the artery doesn't dilate very well if you remove the endothelial cells. So we've developed a technique to test endothelial cell function, and this is the sort of thing that Aga now does in her research and what she learned from us here in Perth. It was really introduced, almost 30 years ago now by David Salameyer and John Deanfield. And they knew that endothelial cells were responsible for increasing the diameter of the artery. So they used high resolution ultrasound probes. Here's the ultrasound machine. Here's a picture of the probe. You can see the brachial artery and the femoral artery being scanned here. This is Andy Haynes, who I work with. And what these guys did is they put a normal blood pressure cuff around the forearm and they pumped it up to about 200 millimeters of mercury, so very high, which cut the blood supply into the forearm for 5 minutes. That means that you generate a lot of vasodilator metabolites in the forearm because there's no oxygen. When you release the cuff, you get a big increase in flow into the arm and through the brachial artery. If you watch this image down here, you can see the velocity of blood in the lower part. This is the pulse wave Doppler. And at some point, I think we release the cuff here and you'll see a big increase in velocity. Maybe if we wait long enough. Or perhaps this image isn't one of those. No, okay, this is just showing that we can detect the diameter of the artery. So this is blood flowing through here. This is the Doppler gate. So this is the velocity of blood. So by putting the velocity together with the diameter, we can measure the blood flow and the shear stress. And when we release the cuff, the artery diameter should increase. In a brachial artery, that increase should be something like 6 to 10%. If it doesn't dilate, then you've got a problem with the endothelial cells. And this is modeling of a brachial artery at rest. This is across the cardiac cycle. You can see all these vectors here. This is studies done using engineering type modeling of flow dynamics, computational flow dynamics. And it shows the level of shear stress on the inside of the wall. So this is a brachial artery bifurcating into a radial and an ulnar artery. You can see at rest, you get these flow waves. During systole, blood goes forward. During diastole, there's a little bit of retrograde flow. When you exercise, and this is leg exercise, all hell breaks loose. The shear stress patterns go crazy. So there's a lot of impact on the vessel wall here that's not present at rest. And that can be a good thing because you're stimulating the inside of the endothelial cells. So let me just move the slide forward if I can. There we go. So with Andrew Mayrana, who now works at Curtin, was my first PhD student, and with Louise Naylor, who I still work with at UWA, we decided to do an experiment many years ago now in type 2 diabetic individuals to determine whether we could increase the amount of artery endothelial function, measured as flow-mediated dilation of the artery, after an exercise training program. So in these diabetics, we took pre-training measures of how fit the artery was and how good the endothelial cells were. And then we trained them for 3 months and repeated that experiment. And we found a significant improvement in the function of the endothelium. So exercise training improved artery health and function. In other studies, Hambrecht and colleagues from Germany did a similar sort of thing. This is published in the New England Journal, where they did the same thing in coronary arteries using quantitative angiography and found that if you exercise train, the endothelial cell function and the ability of the arteries to dilate in response to shear stress improves. Doesn't happen in the control group. This led to a series of studies by our group where Howard Carter was the lead, and I'll just summarize these briefly. There was a series of experiments where we tried to prove that it was shear stress that was causing the artery change in function. So in people obviously most people have two arms, so it's a nice experimental model because you can manipulate one arm and leave the other one alone, and you've got a within subject experimental design. So in these experiments, we did hand grip exercise. You can see in this picture at the top, someone's doing dual hand grip, same amount of exercise on both arms. But on one arm, we had a blood pressure cuff inflated, and this time just a little bit to about 60 millimeters of mercury. And that meant that when you exercised, this arm got a lot of increase in blood flow, but this arm didn't because the cuff impeded it. So we had a model, an experimental model, where shear stress improved in one side, but not the other. And we did 8 weeks of exercise training this way. ARGA's done similar experiments to this. We repeated that experiment, but this time we used leg exercise because leg exercise also increases arm blood flow, and we used the same arm model with a cuff on one arm. Then we thought, well, if shear stress increasing is the reason why exercise is beneficial, then we should be able to increase shear stress even without exercise. So we put both arms into warm water at 42 degrees. And that increased blood flow to both arms, well, to one arm, but again, this cuff impeded it in the other arm, so we had a unilateral difference. And then we heated the legs to see what that did. In all of these experiments, we saw a similar thing. Initially, the endothelial cell function improved before starting to decline, but in the arm that didn't get an increase in shear stress, even though it got the same amount of exercise or the same amount of heat, there was no adaptation in the artery. And in terms of structural change, the size of the artery, and this is the brachial artery, we saw an increase in the size of the artery in the artery that had an increase in shear stress. But if we blocked the increase in shear stress, there was no adaptation. So this is in the same people comparing one arm to the other. It's a powerful experiment or series of experiments. And we concluded two things from this. One is that there's a functional adaptation in the artery, probably caused by an increase in nitric oxide production from endothelial cells. But eventually that function starts to deteriorate, or it doesn't get back to normal. It's still higher, but it does start to plateau. But that's superseded by this structural adaptation, and the artery just gets bigger. So the structural change supersedes and replaces the need for the functional change. But if you don't have an increase in shear stress during these manipulations, you see nothing. So shear stress mediates the change. So to summarize a lot of information here, I think what happens is that you start with a normal artery, you get pulsatile flow down this artery. If you increase that pulsatile flow through exercise as one example, you increase the drag force or the shear stress on the endothelial cells. That causes adaptation of the artery. Initially, it causes just dilation, so a functional change. But if you repeat it over and over again, like you do with exercise training, you get a structural adaptation, so the whole artery gets bigger. And the biochemistry involved is pretty well described now. It's a nitric oxide mediated phenomenon in endothelial cells and a guanylate cyclase, cyclic GMP phenomenon in smooth muscle. All right, so let's summarize what we've talked about so far. Cardiovascular disease is a systemic disease, but the symptoms are localized. So even though you might have a coronary symptom, if that symptom is caused by atherosclerosis, you're likely to have atherosclerosis elsewhere as well, maybe in your brain, maybe in your legs, maybe in your other organs. For me, studying the artery is the end organ. So by that, I mean that a lot of medicine is focused on the end organ. We have specialists we have neurologists, we have renal physicians, we have vascular surgeons, we have cardiologists, and we have ophthalmologists. They're all studying the same disease, just in different organs. So really what they should be is arteriologists, because they're all studying arteries and their function. They're just studying the effects of dysfunction of those arteries in different organ systems. We should be studying it more systemically than that. And that's a problem with the way the medical system is set up. We spend a lot of money on late, heroic, curative management. I would argue we should be spending a hell of a lot more on early preventative management. because all of these disease manifestations are highly preventable, 30 to 40% decrease in risk. So early detection and intervention facilitate optimal prevention, and we've done studies like the ones I just showed you looking at endothelial cell function, even in young children with obesity and type 2 diabetes. And finally, exercise as an intervention has direct effects on the endothelial cells. Exercise also has beneficial effects on lipid levels and blood pressure and hemostasis. So all of the traditional risk factors, exercise is good, a little bit, but it also, on top of that, has direct beneficial effects, sort of biomechanical effects on the artery wall, which decrease the progression of atherosclerosis and improve artery health and function. Okay, that's a lot to take in. Argo, I'm just going to pause here and ask you whether you think we need a bit of a pause on how much time have we spent so far?
It's about 15 minutes left.
15 minutes, okay. Yep. All right, well, I'll start. Is everyone okay for me to continue, or do people want to have a short break or ask some questions at this point, or should I continue?
So for the students, if you want to ask.
This is a good point to stop and pause and see if you followed so far, or if you have any questions so far.
Yeah.
Otherwise, I can continue to the next part.
I guess there are still no questions up to this point, Danny. So probably okay. We can continue, yeah.
All right, I'll do that. Okay, guys. So, like I said in the early slide, there were two parts to this talk. I've talked about prevention and some of the physiological mechanisms, including direct effects that we just summarized. Now I'm going to talk a little bit more about integrative physiology, end-stage heart failure, and what we can do to improve the function of people with heart failure. Firstly, what is heart failure? Heart failure affects about 26 million people. It's very common. It costs a lot of money. It's very expensive to treat. In the United States, $31 billion a year. Costs are increasing, and they're increasing for a couple of reasons. Here's the pattern, the number of people with heart failure per 10,000 over a couple of decades. This was the projected increase in heart failure, and this is what's actually happening. So it's becoming even more common than we thought it would, based on projections. Why is that? It's one of the only types of cardiovascular disease which is increasing on an age-dependent basis. So it's getting more common, not less. And that's partly due to the fact that we're improving the survival of people. So in the Western world, at least, if people have a heart attack these days, they're much more likely to survive it because we have better ways of helping people survive acute myocardial infarction. But if they survive it, they have heart failure. So there's more people with heart failure. We also have better advanced management strategies and drugs. So people with heart failure are living longer. So these are obviously good things, but it does increase the burden of the disease on the healthcare system. So the increase is partly for those reasons. There's also evidence that there's inadequate risk factor control. So although we know that lots of risk factors, including high blood pressure, can lead to heart failure manifesting, there's less and less people taking their drugs properly. So they're not behaving well. And compliance with medications is relatively poor. Some people think less than 50% after a year. The burden of heart failure in terms of how much it costs and how many people are affected is greater than all of these cancers combined. So it's a really impactful disease and it causes a lot of grief. Management of heart failure. This is an interesting slide that I put up. This is, I've got it behind me somewhere. The Harrison's textbook of internal medicine. Maybe this is your textbook, or it wouldn't be the 11th edition because this is from the 1980s, 1987. But the section on heart failure says that what you should do for people with heart failure is decrease their cardiac burden. That means reducing physical activity. This is the guideline. Institute emotional rest so they don't get too stressed, decrease the afterload burden of the heart. Most restriction of physical activity should be bed rest or chair rest. People should rest at home or in hospital. So this was, when I started studying heart failure, this was the medical advice to people. Basically, go home, go to bed, get physically deconditioned, and your prognosis was really poor, actually. About 20 years later, this is 2003, so that's not long, 15 years, I think, 1997 to 2003, everything had changed. This is the American Heart Association guideline on heart failure. And by 2003, they were saying that exercise for heart failure is safe and beneficial, that it improves exercise capacity, including peak oxygen uptake and workload, it improves exercise duration, and it improved patients' quality of life. And they recommend it also improved things like endothelial cell function through mechanisms I just talked about. It decreased sympathetic nervous system activation, and it improves oxygen extraction. So they recommended that when medically stable, all heart failure patients should be referred to an exercise program. So in a 15-year period, we had a textbook telling us under no circumstances exercise people with heart failure. And 15 years later, everything had changed. And now we're saying everyone should exercise if they have heart failure. So it's a really interesting turnaround. This sometimes happens in science and in medicine because we discover new knowledge. And I'm going to talk you through a little bit of that new knowledge and how it came about. So one of the reasons this happened is this study by Donna Mancini and her colleagues. And this is done in 1991, and this is about when I got involved in studying heart failure. This is a really breakthrough study where they measured VO2 peak, or maximum exercise capacity, if you like, in heart failure patients. This is really rare in these days. But they were trying to answer the question, can heart transplantation in people with severe heart failure, sometimes the only thing you can do is a heart transplant, can you safely defer a transplant in people who have preserved exercise capacity? Now, the trouble is there's not enough transplants for the number of people who need them. So you've got to work out who needs them the most. And that's a big question in transplant medicine because you've got to make sure you optimize the benefit to everyone. So giving a heart transplant to someone who's actually pretty functionally okay could be a waste of an organ. You want to really focus on giving the heart to the people who are most impaired. And in 1991, they really didn't know how to do that. They didn't know what measurement was the best measurement of functional impairment. So these guys aimed to see whether measuring oxygen uptake on a treadmill exercise test to determine whether they had preserved exercise capacity was useful. So they did it in 122 patients, and then they separated them in these 122 into 3 groups based on whether their VO2 max or VO2 peak was above or below 14 mils per kilo. In the first group, the patients got transplanted and their 1-year survival was 83%. So if you look at this figure up here, this is the VO2 peak of patients and this is the survival. If their VO2 peak was greater than 18 mils per kilo, that's pretty well preserved. Everyone survived to 12 months. If their VO2 peak was greater than 14%, then 83% of people survived. But if their VO2 peak was less than 10 mils per kilo, so really functionally impaired, then you've got a survival rate of maybe 30%. So VO2 peak did a very good job of discriminating between people who needed more attention, or maybe a transplant now, versus people who could successfully wait a bit longer. Ejection fraction, which is a measure of cardiac function, didn't discriminate. It didn't matter what your ejection fraction was, you basically came out the same. And pulmonary capillary wedge pressure, which is a measure of pulmonary edema or pulmonary loading, also didn't discriminate very well. So in patients who were deemed fit enough to wait, that is, their VO2 peak was pretty well preserved, their 1-year survival was 94%. That's better than if they were given a transplant. So it was pointless giving those people a transplant. You're better off giving it to people who needed it more. So this really changed the way we did transplant medicine because it put VO2 peak measurement on the map. And pretty much after this paper emerged, exercise physiologists started to get jobs in cardiac transplant units because they were the people who could measure VO2 peak And that became a very important measure to the cardiologists who were trying to make these life and death decisions on behalf of their patients. So, if VO2 peak is the only significant predictor of survival in heart failure, it outperforms clinical categorization, it outperforms ejection fraction from echoes, and it outperforms wedge pressure from invasive monitoring, we should be measuring VO2 peak because it's a measure of overall function. How is it measured? Some of you will know. Aga, do these guys know how to do a VO2 peak test? Is that something that they do?
Not really, but they know how to do it.
Okay, they know a little bit about it. I'll just skip over this. A VO2 max or peak test is usually done on a treadmill or a bike ergometer. There are progressive increments in the workload until people either give up or they get symptoms. This is how we do it. We measure the inspired air using the ventilometer. We collect the expired air and we measure the oxygen and carbon dioxide in it. So then we know the oxygen in the inspired air and we know the oxygen in the expired air. The difference must be how much oxygen you used. And we compute that, and there are very good systems now that give you answers immediately to all of that. So this is what a VO2 peak looks like when you increase the workload. Here's the speed on the treadmill increasing. Here's the time on the treadmill increasing. You get this stepwise increase in oxygen consumption. This is in liters a minute. This is in mils per kilo. And it ramps up until you get to a maximum level. And you know that at maximum because if you increment it more, sometimes people plateau. Now, in heart failure, people don't often get to a maximum. They get to a peak value because their symptoms stop them getting to a maximum. But that's what we measure, VO2 peak, the highest VO2 or oxygen uptake achieved before exhaustion occurs. The question, if VO2 peak predicts prognosis in heart failure, the really important question from an exercise physiology perspective is, how do we improve the VO2 peak? How do we make people fitter? And to answer that question, we've got to know what are the determinants of VO2. And this is a little cartoon that shows you some of the factors that affect how much oxygen you can deliver to the muscle to generate energy through oxidative metabolism. Firstly, you rely on the lungs. You rely on ventilation. I've got it says that, I think. Here we go. You rely on ventilation or your breathing. And the function of that breathing is to get oxygen and air down into the pulmonary capillaries where it can transfer into the blood by the process of external respiration. Carbon dioxide goes the other way. Once it's into the pulmonary capillaries, it gets bound to hemoglobin. So if you have a high hemoglobin concentration, you can carry more oxygen. That's a really important determinant of your ability to use oxygen and deliver oxygen. So these are oxygen delivery mechanisms. This is why elite cyclists like Lance Armstrong use EPO, because it increases your hemoglobin, which means your VO2 goes up. Blood is useless unless it gets pushed around, which means you need really good pump function. And you also need to deliver the blood to where you want it to go, to the active muscle instead of inactive organs. So the distribution of blood matters, and that's dependent on vasoconstriction of arteries and vasodilation of other arteries. Once you've done all those things and you've delivered the oxygen all the way down into a capillary in the skeletal muscle, then it gets extracted and anaerobic via a process of aerobic metabolism and sometimes anaerobic metabolism, substrate usage. You can generate energy and cross-bridge linkages occur. So some of these mechanisms are oxygen transport related. It's transporting the oxygen to the tissue. And other ones are oxygen extraction. So it's extraction at the tissue level. And what we're defining here is what's called the Fick principle. The Fick principle says that the volume of oxygen that you can use to generate energy is dependent on oxygen transport multiplied by oxygen extraction. How much oxygen you can move to the skeletal muscle and then how much you can extract once it's there. Those two things are the biggest determinants of VO2 peak. All right. So an interim summary. Functional capacity in humans is optimally assessed using the VO2 peak or a VO2 max test. VO2 peak is the best measure we have in heart failure of who should get a transplant and who can wait. It's also the best overall integrative physiology assessment of function. It outperforms heart measurements, lung measurements, and other measurements based on symptoms. Improving VO2 peak, if you can do that with exercise training, improves survival and longevity. There's a direct link between improving VO2 peak and seeing patients live longer and healthier, and they can wait longer for a transplant. So exercise physiologists have a really key role to play clinically in transplant units and in cardiac rehabilitation. All right. So we're back to the FIT principle here. I mentioned it earlier. This is an MRI showing cardiac function. But VO2, how much oxygen you can use, is dependent on oxygen delivery and oxygen utilization, which we've just been through. Oops, go back up. Yeah. Oxygen delivery is largely dependent on cardiac output. So how much the pump works determines how much blood gets delivered. Cardiac output is determined by heart rate times stroke volume. Stroke volume can be broken down to the difference between end diastolic volume when the ventricle is full and end systolic volume when the ventricle has ejected blood. The difference must be the stroke volume that left the ventricle. So cardiac output is the product of heart rate and stroke volume. And then if you multiply that by the difference between the arterial oxygen going into the tissue, skeletal muscle, and the venous oxygen coming out of the skeletal muscle, that's called AVO2 difference. That's the extraction of oxygen in the tissues, in the skeletal muscle in this case. Pump function times extraction gives you VO2. This is the FIT principle. So heart failure is a complex syndrome. It's characterized by reduced ability of the heart to pump or fill, inadequate cardiac output. Here we have 3 sections by MRI of the ventricle at the apex, at the mid-ventricle, and at the top of the ventricle at the base. You can actually see the aortic semilunar valve blinking open and closed here. And you can see that when this healthy heart contracts, it contracts concentrically towards the midpoint. All of the wall contracts, it's fairly regularly contracting, it's thickening as it's contracting and shortening. This is a heart failure heart, hypokinetic heart, where the ejection fraction, or the amount of blood that leaves the ventricle, is low, it's 30%. And you can see that in this ventricle, it's just not contracting with the same intensity or forcefulness. So there's not enough blood getting out of this ventricle. It'll be logical to assume that the heart, this person, would have a lower VO2 max or VO2 peak than this person because the pump function is better. So let me show you what we call the heart failure paradox. This time we've got echo measurements. These are transthoracic echoes showing the left ventricle here. This is a patient with an ejection fraction of 25%, so pretty not great heart function, but some preserved function. This patient's ventricles hardly contracting at all, so they're not ejecting much blood, 15% ejection fraction. If I asked you to predict who had the highest VO2, you'd probably say this person, case 1, because their ejection fraction and their heart function is better. So they should be able to push more oxygen around. But this is what we see. The VO2 peak in this individual, when we measured it, was 16 mils per kilo, which is 36% of their age predicted value, what it should have been. In this person with worse heart function, their VO2 peak was 36. So that's almost 80% of their predicted function. So in this case, it's paradoxical. Heart function is worse in case 2, but they have better overall VO2 peak. And you might say, well, how is that possible? Because cardiac output is one of the determinants of VO2 peak. The problem is that there are other things that determine VO2 peak. And here's a summary. This is a famous paper in 760 patients with heart failure. Here's VO2 peak on the x-axis and ejection fraction on, this is a measure of heart function. This is an overall measure of human function. There's no correlation between those two things, even in a sample as big as this. So this study by Jay Cohn many years ago led to the hypothesis that VO2 peak is not always limited by cardiac function in heart failure, and there's more going on. So what else could limit it? Well, in some heart failure patients, it's pulmonary function. And you can see this because they're ventilatory equivalents. They have to breathe a lot more to get the same amount of oxygen into the blood. They have more dead space than patients who are normal as well. So the dead space volume as a proportion of tidal volume is higher. So that's a case in some people. Usually that's because of pulmonary congestion. They've got edema in their lungs, and this usually improves a lot if you give people diuretics and dry them out a little bit, but it can be a limit. But in others, the limit is in skeletal muscle. So the heart failure abnormality that you see is exercise intolerance due to shortness of breath. Exercise training can increase exercise tolerance. Other abnormalities in heart failure, you see decreased oxidative capacity, decreased phosphocreatine, and increased acidity. Exercise training reverses all of those things. There's atrophy in skeletal muscle in heart failure. Exercise training causes hypertrophy. There's abnormal histology in heart failure, more type 2 fibers. They become anaerobic animals, really. There's decreased polarization of skeletal muscle. Exercise cures these things. So in each case, the skeletal muscle where you extract oxygen has abnormalities in heart failure, and exercise training is the natural adversary of those abnormalities. So exercise training should be beneficial. So what I'm going to summarize this section about to talk about is the muscle hypothesis of functional limitation. This is proposed by Andrew Coates and colleagues. They're basically saying that if you have left ventricular dysfunction and that's what causes heart failure, that leads to decreased physical inactivity, which leads to muscle wasting, muscle fatigue, and that decreases your VO2 peak. That causes fatigue and breathlessness, which means that you reflexly activate lots of things to try and reverse those things. You get increased sympathetic activity. That causes vasoconstriction, which makes the heart work even harder, and you get even more left ventricular dysfunction. So you're sort of cycling around downwards in a spiral. This hypothesis basically says that if you can reverse the muscle wasting, you can force this to go backwards, and you can prevent the ventricular dysfunction, or at least make it less bad. So we did a study many years ago. This is Andrew and Louise, where we designed an intervention for exercise training heart failure patients. We combined aerobic and resistance exercise. We wanted to do aerobic exercise because we knew it improved functional capacity and body composition, but it does present more cardiovascular stress, and it has little impact on skeletal muscle strength. So we combined it with resistance training, which does those things to skeletal muscle. It did require specialized equipment, but this was called combined resistance, aerobic and resistance training or care. Circuit weight training combines the benefits of aerobic and resistance modes, and that's why we used it. We did an intervention study where we had a control group and an exercise group. Here's the gym, all these people have heart failure. Here's some details of how we exercise them. We did this over just 8 weeks. We found a significant improvement in strength, a significant improvement in VO2 peak. This doesn't look very much, but it's enough to get you off a transplant waiting list. And a significant improvement in physical function, exercise test duration. We also found, so this has implications for prognosis and quality of life. We also measured artery function using the tests I showed you before, and we significantly improved artery function in the heart failure patients. So we decreased their afterload, decreased their blood pressure, improved their cardiac function. So the conclusions here are that exercise training improves functional capacity, strength, and artery health in heart failure. It targets reversible peripheral abnormalities, which can improve prognosis, improve tasks of daily living and quality of life, therefore, and improve perfusion and decrease cardiac afterload burden. My conclusion is that exercise is medicine in heart failure. So that's the end of my talk today. This is my city, this is my university, this is the university campus. This is where Arga did her PhD, next to the swimming pool right here. It's kind of nice. City in the background. It's a city of about 2 million people, spread out a lot. This is Rottnest Island off our coastline. It's very beautiful. This is my daughter doing surfing, and this is her cousin, not surfing so well. And this is Rottnest Island, which if you ever come to Perth, you should definitely visit. And here are the little quokkas who live on Rottnest Island. They're cute little kangaroo type fellas. So thank you for listening. I know it's been a lot of information in a short period of time. I'm trying to pack it in. Happy Christmas to everyone. I hope that we get through these difficult times in Indonesia, and that you have a nice holiday if that's what's coming up for you. I'll stop now. Thanks,
Thank you. Thank you, Danny. I really miss those places.
Yeah. We miss you too, Arga.
There are some questions in the chat box.
Okay, very good.
So from Professor Purwanto. So he asked you about the combining aerobic and resistance training for cardiovascular preventions. Could you explain more in details about the arrangements of this combinations program?
Yeah, so we call it circuit weight training. That's probably not the best description because other people use that term to mean something else. For us, what that means is, if I just bring this slide, I'll share this again, maybe. Oh, I am sharing, good. So I'll get rid of that. Okay, if I go back to this slide, somewhere here. Yeah, so thanks for your question. The type of exercise, I've got a photo, haven't I? Here it is. So here's the gymnasium as we set it up. We put a series of bikes down the middle and sometimes treadmills as well. And around the edges, this only shows you one wall, but it goes around the other side and comes back this side. We had 8 or 12 different machines located around the gym. So what people would do is that we had a timer and a metronome. So the timer was set on 1 minute, and every minute people had to change where they were. So this guy, after a minute of exercising, doing leg press, the buzzer goes off and he goes to a bicycle. And for the next minute, he's on the bike. And then after that minute, he goes to this machine for a minute, and then he goes back to the bike, and then that machine, and then back to the bike. So we had this continuous movement every minute. It was very time efficient. We got around the gym in about 20 to 25 minutes, and people did a very structured step session. Each of the exercises was set according to their own heart rate maximum from a VO2 peak test, and the resistance intervention was set at a percentage of their own individual maximal voluntary contractions. It was largely an aerobic resistance sort of intervention. It wasn't hypertrophy. It was 12 repetitions performed in 45 seconds. So 12 reps at about 55%. And we progressed them as time went on up to these higher values. But that's how we structured it. They moved around the gym. We were trying to combine some weight stimulus. The reason to use machines is that you can get a higher intensity of effort because these people have compromised hearts. You can do more work with their legs if you just isolate the legs instead of using arms and legs. But then we did cycling, which does do that a little bit because that we wanted some stimulus to the cardiovascular system, but we also wanted some stimulus to the skeletal muscle. I hope that answers the question.
Is there any rest between the aerobic and also the weight resistant weight training?
Any what, Arga?
Resting period?
Yeah, so it was about, not much. So it was about a 15-second break. So when the buzzer goes off, these guys get 45 seconds to do cycling.
Mm-hmm.
A buzzer goes and they walk over, and they have 15 to 20 seconds before they have to start exercising. The buzzer goes again. So it's not a lot of rest stations between them. But the resistance exercise was fairly light intensity, 55, so it wasn't really exhaustive. And the cycle intensity started at a fairly modest level. So as they got fitter, we moved them up and progressed them along. It was 8 weeks. It usually took about 3 weeks to get them up to the higher values. And they tolerated it really well. I mean, these are people with an ejection fraction of less than 30%. So, you know, they're pretty functionally impaired when they come to us, but they improve really quickly. And we've been using this intervention for about 25 years now in our transplant unit. Patients really enjoy it. It's group activity. There's a lot of benefit from having the patients do it together. There's a lot of socializing that goes on. They're really a support group for each other, and they encourage each other a lot. And that's one of the biggest benefits, that they help the patients understand that other people are like them. And, you know, when new patients come in and do this, they're often a little bit scared, a little bit worried. They know that they've got a heart problem. They're scared to exercise. And then they walk into a gym and there's 10 other people doing exercise who are just like them. So that helps us a lot with adherence and compliance with the exercise. And people love coming to the gym to do this. Even people who've never exercised in their whole lives and then had a heart attack, they end up in a transplant unit. It's very threatening. They end up coming to the gym and loving it.
Okay. Just wondering, why don't you just doing the aerobic first and then continue with the resistance training rather than instead of doing the circuit weight training?
Yeah, it was largely because we didn't want, we did a study where we did right heart catheters and we had people do cycling while they were recumbent on the bed. And then we had them do leg extension exercise on a bed rig that we had set up. So we were trying to compare the effects of aerobic and resistance exercise on cardiac function acutely. And what we found is that it was actually the aerobic exercise that increased their cardiac burden more than the resistance exercise. And I think it's because the resistance exercise, you contract and then you relax, you contract and then you relax. With the aerobic exercise, it's constant. And it's constant at an elevated level. So when we discovered that that was really the biggest burden on their heart, we wanted to do some aerobic exercise, but we didn't want to overdo it. So we didn't want to do 20 minutes straight because we thought that was the biggest risk. So in this experiment, in this approach, they do 20 minutes of aerobic exercise, but they do it 1 minute at a time with a break in between. And that break is resistance training, which is less burdensome. So that was the rationale. It was to avoid prolonged, intensive cardiac burden, which occurs with aerobic stimuli.
All right. Another question is still from Professor Purwanto. If you can read also in the chat box, if someone with high capacity in cardiopulmonary and also hemoglobin, but low in myoglobin and aerobic capacity, due to the fiber typing of white muscles, so how can they increase the VO2 max? Yeah,
so I mean, there's some overlap with no individual has 100% fast twitch or 100% slow twitch. There's quite a variability between people, but people are not 50-50 either. And there's some evidence that you can move people from fast glycolytic to fast oxidative glycolytic fiber types. Studies like that haven't been done in heart failure. It's very hard to do muscle biopsy studies in heart failure because they're typically anticoagulated and they bleed a lot if you do a muscle biopsy. So we tried to do some muscle biopsy studies, but it involved taking the patients off their warfarin, and the ethics committee wouldn't let us do it. So I think there is some room to move in terms of the skeletal muscle biochemistry. There's also plenty of evidence that capillarization improves, and then you've got some improvement maybe in cardiac function, although some studies tend to indicate that cardiac function is very hard to shift. More recent studies suggest that you can get a slight improvement in pump function. So it's a good question because it brings me back to the Fick equation and the different elements that affect VO2 peak. If you've got a limit in one, you can usually shift one of the others. And you can only shift them as far as the ceiling. So everyone will have a ceiling, and that ceiling is probably cardiac. But you can shift the peripheral factors quite a lot. And we can move patients by 1 or 2 METs in terms of their function in heart failure. People who start with a VO2 peak of 14, we can get them up to 20 sometimes. And that's enough, as I showed you with our Mancini study, that's enough to take them off the transplant waiting list for a while. and they may deteriorate again later, but you've given them more time and you've also made sure that the organ goes to the people who need it the most. So this is really in this end stage heart failure context and in transplantation, it's really about keeping people fit and healthy for as long as you possibly can.
All right, thank you. I saw someone raise their hands. Dr. Adrianta, do you want to ask? Probably just one, two questions. Yeah, Dr. Adrianta.
Good lecture, Professor. Sorry, I cannot open my feed because the Wi-Fi will drop. Can I continue, Arga?
Yes, sure. That's okay.
Okay. Good morning, everyone. I'd like to know, you demonstrate exercise is important in heart failure. What is your latest information about the energy for the heart, the substrate? Is it still like the normal people, or you have to focus on more substrates for heart when you have heart failure? Because I know some pharmacy said switch the substrate for the production of ATP. Second one is, do you use ubiquinone or for heart failure when you exercise them? Thank you.
Thank you, Dr. Adrianta. Yeah.
I think, Arga, I got a lot of breakup in that question. I think the first part was about myocardial cell
It's
metabolism.
about the energy. Is there any changing of the energy system, probably? Energy substrate in the patients of the heart failure? The main energy substrate?
I think the answer to that is probably yes, but it's not something we've studied and I don't really want to speculate. But you know, it's probably etiology driven as well. If you've had an ischemic etiology, it might be different to if you've got an idiopathic dilated cardiomyopathy. It's highly likely that the substrate mix is changing and the intracellular biochemistry is affected. There's obviously not a hell of a lot of information on that in humans because it involves taking myocardial wall biopsies, which we do in heart failure patients from time to time, but it's difficult to do a definitive study on that sort of level. I think it's an interesting question though, because now that we're seeing some, you know, heart failure with preserved ejection fraction, that's probably an active relaxation issue. So you've got, you know, diastolic function measurements becoming very important in the diagnosis of HFpEF. And I think studies will start with better scanning technologies and stress and shear rate measurements that we're doing now. We may be able to get a handle on that in humans about how the energetics is affecting relaxation of the heart. So that's all I can say about that because it's not something that I have at hand. But what was the second question?
Second one is about ubiquinone. How about the supplementations of the ubiquinone?
Yeah, there's a lot of work on coenzyme Q10 about 3 decades ago, and we had a look at it for vascular function, but we didn't see any changes in endothelial cell function with that. Whether it shifts myocardial metabolism and function is probably something that we'd have to look up. It's not something I have at my fingertips either. So, you know, we focused a lot on peripheral factors rather than myocardial factors, although we're also doing echo research using stress strain and 3D echo now because we recognize that maybe the historical idea that you can't shift the impaired ejection fraction may have been an oversimplification. In some patients you probably can, and the earlier you catch it, the better off you are. I think particularly with the preserved ejection fraction, you might be able to intervene earlier with exercise and maybe turn it back. They're good questions, but I'm sorry, I can't really enlighten you much more than that.
Thank you. Okay, so the last opportunity is for Dr. Lily Herawati.
Thank you, Dr. Arga. I'm sorry, I cannot open my camera because my internet is not stable. Thank you, Prof. Danny. It's very interesting lecture. However, I am sorry because I'm late because I had a class, and this is for heart disease, cardiac failure. How we measure VO2 peak in this patient? Is it using echocardiograph, or there is another way to measure? Because this is interesting. Beside the ejection fraction, VO2 peak is very important for this patient. And the second is the VO2 peak in this patient is similar with the VO2 max for the normal patient when we measure with the exercise method. Thank you.
Aga, I'm going to have to ask you to repeat them because I got a lot of breakup at this end. I think it's the internet speed.
So is it the VO2 peak that you VO2 peak is really important for the heart as the determinant factors, as you told us earlier. So is it similar, the VO2 peak in the heart failure patient with the VO2 max in the normal people, normal and healthy people?
So the question is VO2 peak similar to VO2 max?
Yeah. But in the normal healthy people, because in the VO2 peak we know already that they can't reach the VO2 max because of the fatigue.
Yeah. Okay, I think I'm getting a handle on it. So originally when we started doing VO2 peak testing in heart failure, this is 25 years ago, we were using absolute values of VO2 peak, so in mils per kilo per minute, for example. And the study that I put up, the Mancini study, had that analysis. It was, if you were between 14 and 18, you went off the transplant list. If you were below 14, so that's very absolute, right? It's an absolute value. And then people started to get a bit more sophisticated about it, and they said, well, what we really need to be doing, because people differ in age, and we know that VO2 max and VO2 peak change with age, they decrease. So really what we should be doing is comparing the value that people get to their age predicted maximum. And that age predicted maximum is effectively what you would expect from the control group or a healthy group. So, if your VO2 peak is less than 50% of what you would expect from the healthy age max group, then you were listed for transplant. So it got a bit more sophisticated around comparison to age matched controls. In age matched controls, older people, they often don't get to maximum either, no matter how much you push them. They're symptom limited, or they're volitionally exhausted. They stop because they can't move on. They get very heavy legs, or they get tired, they get very breathless, maybe a bit of dyspnea, and they stop prematurely before they hit what was technically be a VO2 max. And there's a series of criteria that you're supposed to hit to define a VO2 max. Not many people hit those when you do a treadmill test or a bike test, particularly a bike test, because you get local fatigue. Mostly athletes do. But, the exercise physiology literature is full of VO2 max measurements. In the clinical domain, almost no one gets to VO2 max, and that includes healthy older people. So we're better off saying, okay, what's the proportion of VO2 peak that these people achieve compared to a VO2 peak that other people who are healthy would achieve? And that's the way that the literature has evolved. What was the second question, Aya?
I forgot what is the second question.
And I couldn't hear it because it just kept breaking up. So maybe we could get it repeated, or.
Dr. Lily, can you repeat it again?
Okay. How to measure VO2 peak in this case? Is using the echo or?
Oh, echo. Yeah. So
echo.
I mean, exercise echo or stress echo is commonly used, as you know, in cardiology to determine whether myocardial function becomes abnormal once you overlay the stress of exercise. But you can't measure VO2 peak using stress echo. You've got to use oxygen uptake measurements using indirect calorimetry. Sometimes we combine indirect calorimetry with a stress echo. There are issues around stress echoes because of the posture that you use. Usually people have to lie down or they have to be semi-recumbent. That changes cardiac loading and it changes a lot of the parameters. Mostly VO2 peak is done on a treadmill upright or even on an upright bike. So there are differences, but the stress echo can definitely give you more insight into the cardiac locus of fatigue. If the heart is really not maintaining an increase in ejection fraction or stroke volume as you ramp up the exercise, that can determine whether the VO2 peak is limited by cardiac function as against peripheral skeletal muscle function. So in some heart failure patients, and I sort of gave an example of this when I looked at the echoes that I showed you, they were resting echoes. There was an echo from someone who had they both had impaired cardiac function, but the one with the worst cardiac function actually had the better VO2. And that's because they were much better at extracting oxygen in the periphery. So even though their heart isn't working, they've compensated for it, and they've compensated very effectively. And they can do that if their periphery is well tuned up. So yeah, I guess that's a good question because it helps us reinforce one of the themes of the talk, which is that we should be thinking about integrative physiology and all of the determinants in that FIC principle that can dictate what the VO2 peak is, because even if you think you're limited in one of them, you might be able to shift the other ones and do some good for the patient. That's really the ultimate exercise.
Thank you,
Thank
Prof.
you.
Dani.
I'm amazed with the data that you present before because I think one of the studies show that they have a really low ejection fractions, but quite good in VO2 peak. It's 36 or something. Yeah.
Yeah, and in all the studies we've done over the years, and there's probably, I don't know, 1,000 patients in exercise training studies that we've done, we've managed to improve VO2 peak in every study, but we hardly ever shift their ejection fraction. So, you know, that goes to prove that you can improve things up to a point. Like I said, there's a ceiling. If you make the periphery really, really good, then you're going to be limited by the cardiac function.
Yeah.
But when most patients come to us initially, they're not limited by their cardiac function. They're limited by the peripheral consequences of that cardiac abnormality. And you can fix that. That is fixable.
Yeah.
The heart may not be fixable, but the periphery is very fixable. And so it's not all is lost. And you know, we've come from on this journey from the 1980s where basically the advice was go home, go to bed and die, to get out of bed, move around as much as you possibly can under good advice and good monitoring.
All right. Thank you so much, Professor Danny Green. Unfortunately, we have very limited time, so we should end this great lecture. So thank you so much one more time, Professor Danny Green, and see you again probably next year, hopefully in person.
Okay, be good to see you in person sometime. See you,
Yeah.
Aga. Bye-bye.
Bye.
Bye-bye, everyone. Thank you.